what I think is a difficult topic today because, well, not that much is really known about it, but there is some substantial overlap to one of the areas of my research. And so what I'd like to do today is to present what I think are really interesting clinical questions that might also be interesting for research. And I think there is a lot of possibility to actually improve the care of some of these patients if we can manage to understand some of the issues that I'll talk about. So I'm going to give you a review of what I found out about Turner syndrome and the aorta, the same thing, and for Noonan syndrome. And in the last third of the talk, I'll talk about the pathophysiology. Since there's nearly nothing known about that, I'm going to have to tell you something about the patho... It's not working. Sounds loud enough to me. Sorry.
I'm sorry.
So now, you can't hear and I can't see. Okay. Yeah? So, okay. Is this better now? Okay. So, what do we know about Turner syndrome? Well, everybody knows this. It's 45X, less frequently chromosomal mosaics, leading to a systemic syndrome with gonadal dysgenesis and a number of other manifestations. It's actually rather common, about 1 in 2,000 or 3,000 women. And so here are some of the pictures that you might see, you might come across in newborns, lymphedema of the dorsa of the hands and feet. You can see the cystic edema in the nuchal area, in the ultrasound, the traces of that postnatally. We often see that there's a wide thorax with widely spaced nipples. We can see here the webbing of the neck on these. Additionally, these girls and women have short stature and reproductive sterility. There's a number of other manifestations, such as attention deficit hyperactivity disorder, some learning disabilities, although most women have normal intelligence with Turner syndrome. I found this interesting. When I was preparing this talk, I looked at the original publication of Dr. Henry Turner from 1938 in Oklahoma, and he described a 23-year-old woman who was considerably disturbed because of the fact that her associates treated her as a little girl because of the stature, and she feared she would never be able to marry and have a home. I guess we would talk about these issues a little bit differently today, but still, I mean, these are really major challenges for affected women. And well, what I think we're interested in today are the cardiological manifestations of this disease, and they're really common. So actually, if I told you the prevalence of something like 1 in 2,500, actually, if we're talking about concepti, about 1 in 200 female fetuses begin life as 45X, and most of these fetuses then actually die on the basis of cardiovascular defects and either are not noticed or lead to an abortion. Postnatally, the prevalence is up to 50%. It depends on the studies that you look at. I'm going to talk about that in the next few slides. Additionally, arterial hypertension is a bit more common than in the general public population. And well, I was especially asked to talk about the aorta, and because of some of these reasons and perhaps other things, there is in fact a substantially increased risk of aortic dissection. So I think these are the sort of textbook things that I'm sure you're all familiar with from your praxis, but just to review this very briefly, something like 10% of the girls have aortic coarctation. I found this that actually, I think the most common form is juxtaductal rather than pre or post, but I think it's a little bit mixed. About up to 30% have a bicuspid aortic valve, and maybe 5% have more or less severe stenosis and regurgitation at the aortic valve. There's a long list of other features that are increased in frequency, and if you take all of the structural manifestations together, you come up with an incidence of structural malformations of about 40% of the women. And well, what does this mean for the aorta and for dissection? Well, there's a substantially increased relative risk of aortic dissection, mainly affecting young adult women. And if you compare this number with this number, so this was a study by, well, this was actually reported, this was a Danish study in the last decade with about several hundred women. The risk was something like 200-fold increased, and this isn't shown here, but if you just look at the women who have Turner syndrome and a bicuspid aortic valve, the risk is something like 500-fold increased. So this is a pretty substantial risk. And so this is one of the first unknowns that I think is really important, and something where the community could make a lot of progress in treating this woman if we did manage to understand this better. So where is this coming from? So you know, we've had a lot of progress in the last decade or two about diseases such as Marfan syndrome and maybe 5 others that I'll talk about briefly. And the question is, well, do these have some commonalities in the pathophysiology? If they did, well, then I would have guidelines that I could maybe adapt, and I could perhaps use medications such as beta blockers or losartan. If they don't, then I can't, and I have to find out how to manage this. And looking at all the literature, even though Turner is really common, there are no real guidelines. There's no evidence-based guidelines for the management, prophylaxis of aortic dissection in the way there are for Marfan syndrome. And so we really don't know the answer to this question. And I just thought I'd sort of show you why might you think this is similar, why might you think this is dissimilar. So this slide shows some things which are different. And you know, so in Marfan, nearly all of the dissections affect the aortic root, type A. In Turner syndrome, about a third affect the descending aorta. In Marfan syndrome, it's extremely rare to see other structural heart defects like coarctation or even bicuspid valve. But this is quite the opposite in Turner syndrome. And in fact, almost all cases of aortic dissection are associated with some other established risk factor, including both structural risk factors and or arterial hypertension. We also see some morphological abnormalities of the aorta. So I'm not a cardiologist, I'm a geneticist, but I can even recognize this myself with my own eyes that this looks a little funny. And in fact, the transverse aortic arch is rather flat, it's elongated, and there's a kink here. And this finding appears to be characteristic of Turner syndrome, and some people actually call this a pseudo coaptation. So that's what was different. What might be similar? And so actually, there haven't been that many studies, but in the studies that have been performed on the histology of the Turner aorta, a lot of them look sort of like Marfan, so they have cystic medial necrosis, Erdhangzell, and another thing which is similar is that it's basically young adults who are most affected. So this is also similar in Marfan syndrome, that it's untreated people from maybe 20 to 40 who actually are most at risk. And this is kind of controversial. There are articles that go both ways, but it seems to be more articles that claim that some Turner patients have a slow dilatation of the aorta prior to aortic dissection. So that would seem perhaps to be similar to Marfan syndrome. So let me switch gears now and move to Noonan syndrome. So what's similar? Well, there's a lot of phenotypic similarities, and in fact, previously, 30 years ago, some people called Noonan syndrome 46 Turner because of all of the similarities. I'll show you some of the phenotypic similarities. These are things that interest a geneticist, a dysmorphologist a lot. Actually, aortic disease is relatively rare, especially dissection is really rare in Noonan syndrome. But there are quite a bit of papers on various things. I'm going to show you some of that. First of all, so what is Noonan syndrome? Well, actually, it's a group of very closely related syndromes. We speak of genetic heterogeneity when a mutation in one of many genes can cause the same or nearly identical syndrome. The most common gene is called PTPN11, but there are a number of others. And what's interesting, in fact, that all of these genes play some role in the RAS-MAP kinase pathway. And so Noonan syndrome and other disorders such as neurofibromatosis, Costello syndrome, have come to be known as the RASopathies, at least for geneticists. All of these are autosomal dominant. What's interesting is that for us also is that the genetic etiology is still unknown for about a quarter of the cases. So if you have any large families, we would actually be interested in talking with you to maybe look into that. So what are some of the commonalities? So we see here the webbing of the neck. Here are some of the typical features. So we see that the eyes are further apart than usual hypertelorism. The nasal bridge is rather flat. There's a ptosis. The ears, you can't really see it here, but they're often rotated, lower than normal, and the helices are a bit thickened in this child. But these findings are highly variable, and they even change a lot in one patient with age. So what are the common things that we see cardiovascularly? Well, the thing that even some medicine students learn is that there's a pulmonary valve stenosis. A lot of the patients also develop a hypertrophic cardiomyopathy, and again, the incidence of a whole panoply of structural abnormalities is slightly increased. So these things might occur with an incidence of a couple of percent. Aortic manifestations, well, coarctation of the aorta, and a couple of recent publications, including one I didn't list here, but by the original Noonan from about 5 years ago, found that maybe up to 10% of the patients have coarctation. Well, aortic dilatation, rarely perhaps dissection, it actually seems to be a rather rare complication. At least, we see patients with Noonan syndrome with some frequency in our outpatient department, and we haven't really heard of this happening very often, actually never. And I just found actually 3 articles in PubMed that describe case studies with relatively mild aortic dilatation that did not require operative therapy. So what's going on? Well, I was actually asked to talk about what's wrong with the aortic wall. And so this is actually one of my areas of research. I'll show you a few slides, not too much about what we do in my lab, but essentially there are 100 hereditary diseases that have some abnormality of the aorta. So you've all heard of Marfan's and some others, but there's quite a few that have this finding. And most of them are so rare that there's not that much research. But if you look at, let's say, the 10 diseases that have had some molecular science research, most of them are characterized by these 3 things. So a cystic medial necrosis, abnormalities of the smooth muscle cells, and importantly, abnormalities of TGF-beta signaling. And essentially, we don't know if this is the case for aortic disease in Turner and Noonan. What I'd like to do now is just present a little bit of this and then speculate as to maybe some of this might actually pertain to these 2 diseases. So I'm sure you know this much better than I do as a non-cardiologist, but this is really typical. So we see areas of sort of cystic medial necrosis, a loss of vascular smooth muscle cells. This is pretty typical of Marfan syndrome, Louis-Dietz syndrome, and by now there's about 5 or 6 other hereditary diseases that have been summarized as thoracic aortic aneurysm and dissection, TAAD. If you look at OMIM, these are numbered from, I think, 1 to 7 or 8 now. And the group of Hal Dietz in Baltimore really revolutionized the field. So I've been working in Marfan for about 15 years now, a long time. And when I started, people thought that it was a structural defect. So the mutated gene in Marfan, fibrillin-1, encodes for a protein of the extracellular matrix, and so it's like a scaffolding, like of a house. And you would think, well, if there's a mutation there, then the tissue is just weakened. Nothing you can do. Sorry. And actually, what Hal Dietz did was to show, and I'll tell you why in a second, that the activity of TGF-beta signaling is increased. And I'll just run you through this slide really, really briefly. But what you see here is basically using an antibody against TGF-beta that the coloring, the staining is showing an increased level of TGF-beta in the lung. Here, he's using an artificial construct, and the so-called SMAD molecules, which are the second messengers for TGF-beta, bind to this nucleotide sequence and basically cause a molecule to make something that gets displayed as a color. So you can really measure the activity of TGF-beta signaling in tissue. And so this, for the first time, showed that there's something going wrong with TGF-beta signaling in Marfan syndrome. And after another 10 extremely elegant publications by Hal Dietz and a couple from some other groups, this is the picture that came up. So these are the microfibrils which are made of fibrillin and a few other proteins. They bind indirectly to TGF-beta. And so if you have a Marfan syndrome and your microfibrils are maybe fragmented because of the primary mutation, what essentially happens is that the TGF-beta gets set free too much. So you have too much active TGF-beta. This then signals through these receptors, causes second messengers via the SMADs, and changes in gene expression that lead to the phenotypic consequences of Marfan syndrome. In Louis-Dietz syndrome, you have mutations directly of these two receptors, and for reasons which are still not completely understood, you get a very similar pathway. And so what Hal Dietz did was to say, well, losartan, which obviously has been in use for a long time as an antihypertensive agent, it has a side effect, not an adverse effect in this case, but something which we want, and that it actually inhibits part of this TGF-beta signaling pathway. And so we thought, well, why not try it? The sort of first choice treatment of Marfan had been propranolol, beta blockers, and so Dietz thought, well, losartan also will lower blood pressure and additionally will have a good effect on TGF-beta. And in fact, in mice, it had an amazing effect. It basically cured the mice. And right now, there's a large-scale trial going on whose result will be published probably by the end of the year on about 700 patients with Marfan syndrome, in which beta blockers are being compared against beta blockers plus losartan. Recently, I'm mentioning this because this is a perhaps crosstalk between Noonan syndrome. The same group actually showed that so-called non-canonical TGF-beta signaling also is abnormal in Marfan syndrome. So the canonical signaling is related to pSMAD. Non-canonical, those are other second messengers that are activated by TGF-beta, including prominently the phospho-ERK system. And so essentially what he's shown is that especially phospho-ERK signaling is correlating with the abnormalities in Marfan syndrome, and they're now trying another agent that might block that. So in addition to that, I'll show you something that my lab has been doing. So we've been interested in matrix degradation products. So this has been known for about 10 years that, especially, this is in knees of, let's say, with osteoarthritis, that you get degradation products of aggrecan and other cartilage tissues that signal back to the cells and say something is wrong with us. The cells then make matrix metalloproteinases and other basically inflammatory substances that lead to more destruction of the matrix, and this turns into a vicious cycle. And so we thought that might be the case in Marfan. And very briefly, we showed that recombinant fragments of Marfan actually can also increase MMP production. One of them has this structure. So this guy here, so-called glycine XX proline glycine motif, or GXXPG, actually hooks up with something called the elastin binding protein. And this EBP is very important. And actually, elastin has about 30 of these motifs. Fibrillin has 3. Fibrillin 2 has 7. A lot of other matrix proteins have lots of these guys, and we think that these are really important to sort of signal the health of the matrix back to the cells that are embedded in the matrix. And so we basically showed by taking extracts of the aorta of a Marfan mouse that these extracts increase macrophage chemotaxis by a factor of about 3 or 4. We also showed that these are macrophages in an area of cystic medial degeneration of a human patient. We showed that macrophages were also statistically significantly increased in Marfan syndrome. We actually also collaborated with Professor Hetzer and his group and did a pilot study basically with some patients and showed that in fact this effect also pertains for human samples. Anyway, so we thought, well, can we actually prevent this from happening? And we decided to use an antibody which basically binds to this GXXPG motif and we think stops this vicious cycle from happening. So it stops these fragments from binding to the cell and leading to upregulation of MMPs and macrophage chemotaxis. And I don't have time to talk about all of this, but essentially these are the wild-type untreated mice, and these are the mice that we treated with the antibody. So there was a dose-dependent decrease in elastin breaks and activation of the TGF-beta system. We also saw that there was a decrease in matrix metalloproteinases. What we saw, so these are the untreated mice, that they have a lot of macrophages here and MMPs here and here that the treated mice, as well as the wild-type mice, do not have. So our treatment basically nearly normalized the appearance of the aorta. And we're now actually considering if this can be used in a clinical context. So what might this have to do with Turner and Noonan syndrome? Well, there's a number of ideas. This hypothesis might have something to do with it. It's basically saying that jugular lymphatic sac obstruction in the fetuses is distending, which we see here, is basically leading to distension of the thoracic ducts, which leads to a pressure problem in the developing heart, leading to impaired development of the aortic valve and arch. But what I guess more genetically inclined people think is that, well, that might be the case, but probably one thing that could be happening is that genes on the so-called pseudo-autosomal region, which are at the ends of the Y and the X chromosome, so these are actually like an autosome, so even women normally have expression of genes from both copies of the X. Of course, the rest of the X chromosome undergoes X inactivation, so normal women just have one expression of one copy. And essentially, looking at the literature, there's a lot of speculation that some of these genes might be interacting with the TGF-beta system. To the best of my knowledge, none of this is so plausible or obvious that we can tell which of the approximately 30 genes on these intervals might actually be responsible, although there are some speculations in papers. Finally, in Noonan, well, I didn't find anything. I didn't even find speculation about the molecular basis of aortic disease in that syndrome. Well, I think for the coarctation, I basically think nobody really knows, but presumably it has something to do with this, the RAS MAPK pathway, which affects growth in a multitude of ways. Interestingly, signaling through the RAS pathway, which starts with growth factors or cytokines, a lot of it, not all of it, but a lot of it goes through ERK, which Hal Dietz showed to be responsible for manifestations in Marfan syndrome. So what I would speculate is that the intersection of this pathway with the TGF-beta pathway is a very plausible explanation for aortic dilatation that's occasionally seen in Noonan syndrome. So thank you for following me through this, I guess, genetic discourse, which it's my world, it's not maybe your day-to-day world, but I think that we can summarize that we still really don't know a lot at all about these diseases. There's essentially no published research on the molecular basis of these diseases, and there's not even good clinical studies. So a clinician will not really know how to optimally manage these patients. And so there's many opportunities that are open now for clinical and scientific research in the field. I've actually, in the process of preparing this lecture, I've started to get rather interested in this topic, so who knows. So thank you for listening. These are some of the people from my group who did the work I showed you, and happy to take questions.